Hi, hello. Am I audible to everyone? Hi, hello everyone. Hi. Am I audible? Okay, just let me know in the form of a thumbs up or a nod if I am audible to everyone. Yes. Hello, hello. Hi. Hi. So, till few more people join in, we'll wait for a minute or two. Till then, I'll introduce myself with you all. Myself, Kaustubh Kakade. I am a final year student and I'm a topper in my first two batches. So, yeah, that's all what I can tell you about myself. So, we all are going to discuss interesting topics, important topics in the form of MCQs, figures, images, flowcharts, diagrams, different related to system wise approach, right? Great. Fine. Okay. So now I think many of you have already joined in. So let's start with the session. So we have 20 questions overall to discuss. The system which we are starting today is cardiology, under which, as told in the timetable or the schedule that you have already received, we are having anatomy, embryology, surgery, and pathology related to cardiovascular system. So we have a mixed bag of question. It's important that you are able to apply them all together, not getting confused by the type of questions the examiner asks to you all, right? Fine. So let's start with the session. Okay, so I am audible to everyone. Fine. So let me know first before the session that how was the test? If any one of you have given that, let me know how was the test, how were the questions. Yes, how are the questions? Okay, I'm not getting the chats. Fine, we'll come back. Okay, what we are going to follow the pattern is I'll discuss the question with you. We'll take a pause of a minute or so, take some doubts, and let's then go to the next question, right? Fine. So let's start with the first question. The first question, which is in front of you, is a clinical case. Now, the thing is that we get confused or we get afraid by looking at a very big question, a very big clinical question coming in front of you, right? Fine. So now it's very simple. A very basic strategy has to be followed for such questions is that you need to understand what is basically asked first, right? So the first thing that you have to do is you have to first think for as to what has been asked in this question, right? So first read the last line that has been given. So the thing that is asked is what is the reason for the given situation. So they are basically asking you what is the reason for the given situation. And if you look at the options, you will get they are talking something related to coronary artery, right? They are talking something related to coronary artery. Yes, Kunika, absolutely right. It is option A. Fine, correct. So see, it's very simple. You have got that it's talking about coronary artery. Now you need to just highlight certain important words, right? What are those important words? See, 50-year-old man who has come with chest pain, left upper arm. ECG is showing inferior wall MI. Now it's very simple that they have already given you the diagnosis and they have made it very easy for you. It has made very easy for you. If you look at this given figure in this given question, sorry, you are already having the diagnosis that it is an inferior wall MI. So you just need to tell me that what is the blood supply of the inferior wall? You just need to know what is the blood supply of the inferior wall, right? So now for that, let's quickly discuss what is the blood supply of inferior wall, right? Okay, one sec. Okay, so this is overall the blood supply that you can see in front of you. Fine. Sorry for the disturbance. Some hang might be going on in between. Fine. So see, you are having, this is the figure that you are shown. So the basic thing is you are having aorta coming from the left ventricle, right? From the aorta, you are having three structures. If you know, there are three basic structure, one anterior coronary sinus and two posterior coronary sinuses, right? Or aortic sinuses. The one left posterior, right posterior, and one anterior. Now, originating from them are your coronary arteries. Now, if you look at this very carefully, your right coronary artery is originating from where? It is originating from anterior aortic sinus, and you can appreciate this right coronary artery is passing forwards in the atrioventricular groove, right, in the AV groove that is between the right atrium and the right ventricle, right. Now when it goes posteriorly, it further continues as a same artery continuing as a branch or a terminal as PDA. PDA is posterior descending artery, posterior descending artery, right? Let me increase the size a bit. Okay. So posterior descending artery, it is nothing but a continuation of right coronary artery, right? Now, if you observe very carefully, you will understand that at the same time you are having the left aortic sinus giving rise to left coronary artery. This left coronary artery gives one branch, that is the circumflex artery, and then it gives left anterior descending. Left anterior descending, where it is present? It is present in the interventricular groove. Interventricular groove, right? It is present in interventricular groove, and then it passes posteriorly, and you can appreciate this artery going posteriorly and anastomosing with the posterior descending artery. Can anyone tell me quickly what is this point called? What is this point called? Yeah. Okay, right. This is called as a crus. This is called a crus of the heart. This is called crus of the heart. Fine. This is called crus of the heart. Okay. Now, at the same time, you can appreciate this uh, circumflex artery. This circumflex artery, left circumflex artery, is also going posteriorly, running on the wall of left ventricle. Now, if you have seen, there is one more artery which is running over here. This artery. Okay, this artery is a acute marginal artery. This is acute marginal artery. Fine. This is acute marginal artery. It is going along the inferior border of the heart. Now, if we want to see it further, then you would understand that how is the blood supply going basically. So if you want to understand this, then the left anterior descending artery, this is supplying two-third of the two-third, that is the anterior two-third of the interventricular septum, and it is also supplying the anterolateral wall, that is the papillary muscles, especially papillary muscles specially, right? Then you are also having the next branch, that is the posterior descending artery. Where is this posterior descending artery basically supplying? This is supplying AV node. Then it supplies posterior one-third of interventricular septum. Then it supplies the posterior two-third of walls, right, of the ventricles basically. Okay, it supplies posterior two-third, posterior one-third of the ventricular walls, and it also supplies the posteromedial part of the papillary muscles. Okay, so the posteromedial papillary muscles of the left ventricle are supplied by posterior descending artery. Okay, one sec. Okay, I think now it's visible. Fine. Then after this, you are having the right coronary artery. What does right coronary artery supply? It supplies SA node. It supplies SA node. Now, very, very important thing that you need to understand is that SA node is the only part of the heart which has blood supply which is independent. Okay, this blood supply is independent of dominance. Okay, now can anyone tell me what is dominance? What do you mean by dominance? Yes, can anyone tell me what is dominance? Okay, fine, it's good. What do you mean by dominance? Okay, right. So dominance is nothing but which artery is the main that supplies the heart. Which artery is the main that supplies the heart. So now let's discuss quite quickly about the dominance, which is one of the important points again. So if you see about the dominance part, then you should know that 85% is supplied by the right coronary is the main dominance, right? 85% of the individuals, they show right coronary dominance. About 8% of them, they show left coronary dominance, and about 7% of the individuals, they show co-dominance. They show co-dominance. Yes, as Kunika has already noted for us, it's absolutely right that posterior interventricular groove, it contains either of the two, whichever artery is present in the posterior interventricular groove, that is going to be the dominant artery. That is going to be the dominant artery. Now coming back to this question, as we have already discussed, now you should understand that inferior wall. What is inferior wall? Inferior wall is nothing but, it is nothing but formed by the right ventricle proper, that is the base of the right ventricle, and the atria, and this part is basically chiefly supplied by your right coronary artery, and that's why the correct answer in this question is right coronary artery. Is that clear to everyone? Is that clear to everyone? Okay, great. Fine. So now let's go to the next question. The second question. Second question is a 66-year-old man who has come who is already a known case of mitral stenosis, right? So you're having an old aged individual who already has mitral stenosis, and then he has come with dysphagia. Dysphagia means I'm going really very basic. It's nothing but difficulty in swallowing. It is nothing but difficulty in swallowing. Right now, if you observe this further, they have given certain points which say that your oropharynx is normal, transesophageal ultrasound is taken. These are all things which are deviating you from your answer, or they are basically written to confuse you or waste your time. That's the only thing that basically examiner has a motto for most of the times. Yes, to engage you and waste your time, and then it becomes a situation where you become anxious. We don't really want that. So basically we have to simply jump in the question that asks that which chamber enlargement is related to this question. Okay, which chamber enlargement is related to this question. Fine. If you observe this really carefully, you just need to apply anatomy. Okay, this is nothing but a simple question of anatomy. It is nothing related to medicine. It is nothing related to surgery. Only and the only thing that you need to know about over here is the anatomy of your mediastinum. Fine. So now let's try going see. Okay, this is the figure that shows basically your mediastinum, right? It shows mediastinum. If you observe the mediastinum, certain important points that we should know about mediastinum is that how the mediastinum is basically anatomically located. If you observe this, what is this? This is, yes, I am getting right answers. I'm having actually mixed answers for this question. Mansi says left atrium, Candy Prabha says right atrium, Nishan says left, Kistai says left ventricle. Okay, let's focus here. See, this is your manubrium above, basically, and this is the body of sternum. This is the manubrium, and this is the body of the sternum. Just behind that, you have mediastinum. Do you know why the name has come up as mediastinum? This is actually changeover of word. If you observe this really carefully, this says media and sternum. Okay, sternum has come from the word of sternum, and media means beneath. So mediastinum is nothing but the anatomical structures located beneath the sternum. That is mediastinum. If you observe it, you would get a very basic thing related to this question. Very basic thing. See, this is the left atrium. This is the esophagus. Okay. Left atrium and the esophagus. Fine. If you observe, this esophagus is present posterior to the left atrium, right? Let's draw a very basic diagram. A very basic simple block diagram related to this. See. Imagine this to be a sternum. Imagine this to be a sternum. Here you are having posteriorly, this is your heart. Okay. So you are having the left lateral view of the mediastinum, right? So if you have a look at this heart very carefully, you will observe that the main component which is formed here is the interventricular groove in between somewhere. You are having your right ventricle ka thoda sa part, you are having your left ventricle ka thoda sa part, but the major part of left atrium is present over here, right? And posteriorly passing is your esophagus. So posteriorly passing is your esophagus. So if you observe this really carefully, a very basic and simple thing. What will happen if your left atrium enlarges? What will happen if your left atrium enlarges? Very simple. It will compress over the esophagus and cause difficulty in swallowing, right? So that is what they have basically asked over here. So the answer to this question becomes left atrium. The answer to this question becomes left atrium, right? Correct? Okay, great. Fine. Let's go to the next question. I think this is quite enough. There are no doubts till now. Fine. Okay, great. Fine. Next. So the next question is again a clinical case. Looks a bit tough, but is really easy. Mind me, it's really easy. See, you are having a 50-year-old man who was brought with sudden onset chest pain radiating to the left upper arm and the neck. So basically, this is clinically telling that a pain going to the neck, that is radiating to the neck and the left upper arm. What is the diagnosis? What is the diagnosis? Diagnosis is nothing but, yes, very simple. It is an acute myocardial infarction. This is an acute myocardial infarction, right? So now, if you read further, you will get that the patient was admitted to the ICU and he died the next day due to atrial fibrillation. Nothing to do with the question. It's very simple. If you highlight, see, he dies a day later. And then they have asked that at this point, what should be the light microscopic changes? So now tell me, a day later, what does this mean? They want you to ask, basically, they want you to ask what happens to the light microscopy exactly at 24 hours. What happens to the light microscopy exactly at the 24 hours? Yes, I am getting absolutely correct answers till now. Very good. I am getting absolutely correct answers till now. Great. So now let's go and quickly discuss a few important points related to the changes in acute MI. Fine. This is really an important topic, and I think you should not miss out on this topic whenever you are revising the pathology part of the cardiology. You should always revise this specific thing given in the question, right? Now let's start and discuss this. So at 0 to 24 hours, at 0 to 24 hours, what basically happens is that at gross pathology, you get something called as dark mottling. Why there is dark mottling? Because there is a infarction. There is a infarction which has undergone in that specific area, and when a cardiac tissue undergoes infarction, it becomes mottled and appears dark, right? Okay, then under light microscopy you get waviness of the fibers. This is the only word I want you to note down in this table: waviness of fibers on light microscopy. See, if you can appreciate, this is the normal tissue and this is the MI wala tissue. Okay, this is the normal tissue, this is the MI wala tissue. You will observe that basically in the normal tissue this branching pattern is very uniform, but if you observe in this area in an acute MI, you can observe the fibers have become quite wavy. The fibers have become quite wavy. This appearance is your wavy fibers occurs at 0 to 24 hours. Now the fun step question ahead comes up to your mind is going to be, what are the complications related to this? So the complications which are possible now in our patient, the patient has died. The patient has died. But what are the possible complications? Remember, atrial fibrillation, ventricular fibrillation, heart failure, and cardiogenic shock. These are the possible complications in the first 24 hours. These are the possible complications in the first 24 hours, that is atrial fibrillation, ventricular fibrillation, heart failure, and shock. Fine. Okay. Next, when you go to the first to third day, what then happens? Now, in this area starts hyperemia. Now, you will imagine that why hyperemia begins. Now, remember, if the death has occurred at 1 to 3 days, there will not be any hyperemia. But this will occur if the patient is alive. If the patient is alive. Now, a very basic things. Yes, yes, Nishant. As you have noted from MI, there were three questions in FMGE. This is the really important table you need to know, right? Okay. Now, patient is alive. Here, the cardiac tissue is undergoing ischemia. So, what will happen? This tissue, cardiac tissue, is undergoing ischemia. So what will be happening? That will cause a reflex release of VEGF. And because of this VEGF, that there happens a milder amount of neovascularization that causes hyperemia in this areas. Okay, that causes hyperemia in this area. Now what happens in the light microscopy on 1 to 3rd day? Remember, there is going to be extensive coagulative necrosis, extensive coagulative necrosis that will happen in this specific area, right, in the heart. But at the same time, you will also observe, if you can observe, you are having this structures which are infiltrating in between. These are nothing but neutrophil. So starts of neutrophilic infiltration. So there is a beginning of neutrophilic infiltration at this point of time. Fine. Okay. There is no possible complication as such in 1 to 3rd day. But now let's go to this area, that is 3rd to 4th. Fine. Okay. Now what happens to 3rd to 14th? Now 3rd to 14th, what happens? The central area starts becoming softened. So the gross finding is a hyperemic border with central softening. Central softening. Fine. Now, what happens with histopath in this? Now, 3rd to 14th day, what happens is you are having macrophages, and you are having granulation tissue, right? Can you have, and you are also having granulation tissue. Fine. You are also having granulation tissue.